Welcome to the April 9th, 2025 regular meeting of the Washington Township Healthcare District Board of Directors. Public notice for this meeting has been posted appropriately on our website. Tonight's meeting is in person and is also accessible by Zoom. I ask that you please mute your system until such time as you need to speak. We are recording tonight's regular session of the board meeting. It will be posted on our website for future viewing. Cheryl, would you please take the roll?
Yes. Director Wallace.
Present.
Director Nicholson.
Present.
Director Yee.
Present.
Director Stewart. Director Epen.
Present.
Thank you. We'll now move on to our oral communication. Members of the public are invited to speak during oral communication. When prompted, please state your name for the record, then proceed with your statement not to exceed 3 minutes on issues or concerns not on the agenda and within the subject matter of jurisdiction of the board. Are there any members of the public who would like to speak at this meeting?
Yeah, I know we're just, given that there was we've been in this new facility, I know Tina was just going to check to see, because we had heard there may be somebody here tonight. So why don't you check to see if there's anyone online that wants to speak?
Is there anyone on Zoom that would like to speak tonight?
Right, well, we can,
at your discretion, you can open up, revisit that.
That's what I was going to say,
Yeah.
could we revisit it if we do, yeah.
Okay, well, that's good. So, Cheryl, are there any written communication?
No written communication.
Okay, we will now move on to our consent calendar. The consent calendar consists of those agenda items that the board will approve with one motion unless either a member of the board or a member of the public requests to remove an agenda item from the consent calendar. If any items are removed from the consent calendar, the board will take action on the removed agenda item later in the meeting under the action item heading of the agenda. Does anyone on the board want to remove an agenda item from the consent calendar? Does any member of the public want to remove an agenda item from the consent calendar? May I have a motion to approve the consent calendar items A and B?
Yes, Mr. President, I move that the Board of Directors approve the consent calendar, items A and B.
Second.
Okay.
I did. All right, Cheryl, please.
Director Wallace.
Aye.
Director Nicholson.
Aye.
Director Yee.
Aye.
Director Stewart. Director Epen.
Aye.
Thank you.
I would like us to go back to oral communications. We do have 4 people that would like to address the board this evening.
Okay, so let me advise.
When they come
Mhm.
when they come in, you can.
Okay,
They're filling out the cards.
oh, okay.
They'll be right in.
Go, yeah, why don't you skip?
They're going to get 3 minutes.
Yep.
No one on time. No one on.
Yeah. Yeah. Were they across the street?
Yeah, they just go over there. Yeah. They're numbered.
Okay. Welcome, everyone. I just wanted to let you know that happy to have you here. Please state your name for the record and then proceed with your statements to exceed 3 minutes on issues or any concerns that are not on the agenda and within the subject matter of the jurisdiction of the board. So with that, will Grant Hill please step forward?
That's me.
Okay.
A few folks. So Grant Hill with ESP Local 20. I'm the staff rep. I think by this point you guys should know me after 5 years, I would hope. So good to see everybody. Figured out this was the right place because somebody came searching for us and said when you see security, that's the right place. So basically we're here today. We have an unfortunate situation for rehab where we have some physical therapy assistants that are paid below market. And so we're here asking the board to consider, it's 3 folks. Originally, we had 4, and now we only have 3 because one unfortunately resigned because they're able to get higher pay somewhere else. And so we're really hoping that the board would consider looking at their pay. We can email you some comparables and where the market's at. HR has a copy of this. Their department manager has a copy of this. So this is something that we'd like you guys to consider because we don't want to lose these folks that, they want to stay at Washington. We have people that have worked here for years and years and years, and they want to build their lives here. But if you can get, more pay down the street and the economy that we're living in, it makes it difficult, right? So we're hoping that you guys will look at it. It has been mentioned by some in management that this hasn't been done before. So we had a meeting with HR a couple months ago, and I believe it was one of the directors made a comment that this hasn't been done for the unions or at Washington before. But in fact, about a year and a half ago, maybe 2 years ago, we weren't even in negotiations, but we did this for the scientists. So long story short, they saw that the scientists were underpaid, and we were losing some of the folks. They saw that they were below market. So what they did is they changed the wage scale. They increased the wage scale and moved people up a couple steps. And then you guys also did the sign-on bonuses for folks. So we're not talking about 10 people. We're not talking about 50 or 100 people. We're talking about 3 folks, and we've already lost 1 of them. So out of the 4, now we have 3. We don't want to lose more. And so we're here today just to respectfully ask you guys to look at the market, see where we're at, and we're hoping that we can make this adjustment for them. And I will send you guys the comparables by email so you guys can see it, and I can send a copy to you as well, really, so everybody has it and you guys can take a look. So
30 seconds.
Yeah, so we appreciate your guys' time today, and we have some other folks that are going to make some comments, and a little sweaty from being out in the sun and going up the stairs here, but it's good to see you guys. Thank you.
Thank you.
Thank you, Grant. The next is Prabhjot Kaur.
Hi,
Hi.
I'm Babjot Kaur. I'm a physical therapist here at Washington Hospital, and I'm here to just give you guys an overview about the PTAs, just in case you're not familiar with their role in the hospital. They attend a 2-year program. They are licensed professionals. They take a board exam before they come to work. They have to take CEU continuing education classes every year, and they work under the physical therapist. They cannot perform an evaluation. As therapists, we perform the evaluation. We set out a treatment plan for our patients, and then we trust our PTAs to come and make sure that those goals are met, because we share the same goals with the hospital. Reduced length of stay, good outcomes. We want our patients going home, not to a nursing home, right? We want them to get on with their lives. And our PTAs help us mobilize our patients. They do family training, patient training, and here is involved in wound care, so they're part of our wound care team, IJR. They're working all over the hospital. We really value them a lot when they come to us and say, any of our PTAs, and they tell me that, hey, there's been a change in status with a patient. Could you address this? Or you mentioned this patient needs to go to a nursing home. They're mobilizing better. They can walk to the bathroom. They're more steady. I think they could go home with their family. And that lets us change the goals and facilitate that safe discharge home. So they are very valuable. I trust them a lot. They work in our ICU. They mobilize our intubated patients. That's, again, in a very high-risk environment, and they are very safe and capable in their hands. I trust our patients with them. It's not that easy to get some skilled therapists that we have, and I really value them, and I would not want to lose them. I wanted to share that with you and give that to your consideration. Thank you.
Thank you.
Thank you.
Thank you. Next will be Christian Salcido.
Hi, everyone. Good evening or good afternoon. My name is Christian Salcido. I've been working here for about 8 years now. I started off as a rehab aide and transitioned to a physical therapist assistant. So back then, I was asked where I wanted to be 5 years from then. And I told my director I wanted to stay here at Washington Hospital. It was the hospital's mission to provide and to put our patients first And it resounded with my passion in helping others in the community as well. Now, I'm really confident that if you were to ask any of my patients what their experiences were like working with me, many of them will tell you that they felt truly cared for, seen, and heard, because I always make it a point to see them as my own family, friends, and loved ones. I'm passionate with helping others, but it becomes difficult to sustain this level of care, knowing that I also have to work a second job to make ends meet. So the cost of living has already made it really difficult for me, and it continues to increase. A lot of the pay that I make already, 80% of it goes towards my basic needs. And that's not even including the student loans I have to pay off as well. So many of my colleagues have already left for other jobs that also saw value in their work. But I continue to stay with the belief that Washington values me and what I have contributed towards this organization. I'm just asking to be heard, to be seen, be treated fairly as I have for my patients here. I just want to be proven right that staying at Washington was the best decision I've made. I've had multiple accounts already through my colleagues, hearing about patients talking about me and how much of a lasting impact I've made on them. And I believe it's those experiences that they've gained that help define the face of Washington Health. So I do need your support, and we all do need your support, that me and I can continue staying here to provide the level of care that I want to.
Thank you.
Thank you.
Thank you.
Thank you. Next is Ann Mursel.
Hi, hello everyone. I'm Anna Saul, and I've been working at Washington Hospital. Here you know this.
Oh, we're friends, it's okay.
Washington Hospital, sorry. For 26 years. I started my journey in 1998 as a rehab aide before going back to school to become a physical therapist assistant. Throughout my time, I've remained committed to our patients and department and hospital. But I'm also here to speak about fairness. For 6 years after I've had already maxed out my step increase, my department now saw no wage adjustment. We were left with no other choice but to unite, to advocate for ourselves and our future. And let me make this clear. Don't let the word assistant mislead you. As a physical therapy assistant at Washington Hospital, my colleagues and I consistently provide the same high level of care across the department. I am one of the few who serve in the wound care team, apply negative pressure wound therapy, and essential treatments that promote healing. We also serve as mentors. I have the privilege of guiding students who later join our team. Dave was a student that I mentored. He joined our team after graduation and worked alongside me for 8 years. But just recently, he had moved on to another hospital. A difficult choice, but one that offered better pay. The 3 PTAs were denied the one-time 3% adjustment wage, basic pay rate, which the rest of our department team received. He now earns more than I do, even though I've served this hospital and community for nearly 3 decades and have more clinical experience. That should never be reality for loyalty, skill, and long-serving employees. We're not asking for anything excessive. We're simply asking for fair market wage so that we can continue to provide the care for our community. For many of us, this is just a job. It's our calling and it's our purpose. I envision my future here. I want to retire here. I have 4 daughters, and 3 of whom I was born in this hospital.
30 seconds.
This place is part of my family story. I ask you to honor the commitment, but not just for mine, but for every physical therapy assistant who shows up every day, give their all and deserve to be seen and heard and valued.
Thank you.
Other speakers? Okay, are there any speakers online? Well, thank you.
Thank you.
Thank you.
Thank you. Appreciate you.
Okay, Kimberly will
All right.
continue with the meeting.
Next, we have a presentation by Dr. Carmen Arcawilli and Dr. Cranthi Achanta, and it's medical missions to the Philippines. So I am going to just do a short bio on both of them. I know that they're well known to many of us, and appreciate them joining us this evening. Dr. Carmen Acawilli retired from clinical practice in January of 2024 after a highly distinguished career in the medical field, particularly in pulmonary critical care and internal medicine. Her leadership roles, such as developing the intensivist program in 2008 and serving as the medical director of critical care, intermediate care, and the palliative care program, showcase her expertise and dedication to improving patient care. We're also very appreciative that she is continuing her involvement with the Washington Health Transitional Care Program after her retirement. She's board certified in internal medicine and critical care. Dr. Cranthi Achanta completed his medical school in India. He then completed a general surgery residency at Tufts University affiliated hospitals in Boston, Massachusetts, followed by a fellowship in minimally invasive surgery at the University of Southern California. Since joining Washington Health in 2001, Dr. Achanta has held several leadership positions, shaping this institution's clinical excellence and operational efficiency, including Chief of Medical Staff from 2015 to 2017, and Utilization Management Chair and Physician Advisor from 2017 to 2024. Dr. Achanta is board certified and fellowship trained expert in laparoscopic, robotic, and general surgery, and recently earned a certificate of Da Vinci robot training in May of 2024. All right, I'm going to turn it over to you, Dr. Acawilli and Dr. Achanta.
Thank you very much. Can you hear me?
Yes, yes.
Okay, good. Good evening, everybody. Thank you for your introduction. Just want to let you know that the Philippine Med of Northern California has been here for the last 53 years, and we started the mission in 1986, about 39 years ago. And the main objective was to reach out and give back to thousands of indigenous Filipino in the underserved communities who are in need of medical care. For the medical mission volunteer, just in case you're interested, each has been an adventure, an eye-opener, and a learning experience, opening up myriads of opportunities to make a difference in the lives of the people they touch. The volunteers, though, pay for their own transport, for lodging, and application for a Philippine license to practice 1 week in the Philippines. All medicines we bring, supplies, and services are free, but we partner with local health and government services. So if you look at the North America here on the left side and the Philippines on the right side with the arrow, it takes about 7,120 miles to go, but it's Pacific Ocean, okay? It's not across Africa. So the airplane will go around the Pacific kind of thing. Okay. So next slide, please. So in 2024, we went to Pangasinan in the Luzon area, the Big Island. And in 2025, this year, we went to Cabanatuan. So you see, the Pangasinan is close to the South China Sea. That's where we were in 2024, me and Dr. Achanta. Next slide, please. So it needs a lot of preparation. 1 year before, we have meetings. We also vet for the applicants, because we cannot just get anybody. We need good, or we are setting the standards as like a US standard. Next, please. We collect a lot of donations, and Washington Health is one of our major donors from Seton, from other places. We are the basement of the Maurice Hyman Pavilion, and these are all stuff like PPE that are substandard and are no longer needed. So we go and scavenge our way there then. In the next slide, but we have to get the approval of our foundation health chairman. That's Sarah, our director. Next slide, please. So we sort the supplies, pack them up, and next slide. and then we prepare for our journey to the Philippines. So some of the surplus also, like 2 years ago, we had double X, very large um, scrub pants that was donated to Washington Hospital by FIGS, and they did not want it anymore. So instead of throwing it away, I took it and brought it home, and was appreciated by these nurses, local nurses and MAs, because it will only take 50 cents to repair the double X pants. So they were very appreciative, and they thanked the Washington Health Foundation. Next slide, please. So after 15 hours flight, we arrive in Manila, and then I tour them a little bit. They want to sleep, but I tour them a little bit to the Manila Luneta Park, where our national hero is there, Jose Rizal. Next slide. These are the medical mission volunteers from Washington Health, current and former employees. I took Dr. Achanta with me in 2024, and he took his 2 OR nurses team with him. I also had Athena Albino from ICU, and I made her the chief of the ICU and the recovery room. Gina Arguelles down lower is retired from the nursery. She's now the lead of ambulatory care for our mission. And Biomed, Dan Dublin, is the head of the Biomed department. Next slide. So we were welcomed warmly by the municipality. Next slide, please. The mayor is beautiful. They welcome us. Most of these participants, volunteers, are outpatient because the OR people are already in the OR at 6 o'clock in the morning. This is around 7:30. Next slide. So while we are having our meeting, they're already waiting outside. The left side is, on your left is the 2024, and on the right, a little bit better with seats, is 2025. Next slide, please. Just giving you the heads up. So the triage services are formed by, most of them are ICU nurses, by the way, but they're outpatient. And I also made them our first aid team. I have an AED, first aid kit, and all those things. And we formed the urgent care unit. I was their physician at this time, aside from triaging. The AED was a donation from Fremont Bank. We use it for our community outreach also here locally. Thank you. Next slide. So this is how the medical services look. On the left side is the 2024 mission. They're in cubicles, a little bit better, but on the right side, they're invisible lines. So next slide. I want to share a case with you that I saw. This patient has chronic dermatitis or skin irritation that hasn't been better. He cannot afford to go and see a dermatologist. And I was not going to do it because there's a lot of questions that you have to ask for skincare, you know, where they come from, their genetics and things like that. And happily, it's good that I asked because this patient was a painter, and about 1 or 2 weeks after painting, after his job, then he would develop all these rashes with sometimes with blebs and things like that. So it's environmental and it's toxic. So I told him I cannot tell him not to work anymore as a painter, but he can probably do other job in construction. So I gave this patient some steroids and steroid cream and asked him to come back in, at the end of our mission. And it was slightly better. So it's probably environmental contact dermatitis kind of a problem. Just want to show you. And why is it that it's also under the t-shirt? Because he takes out his shirt while painting because it's so hot in the Philippines. So next slide. The pediatric services is busy, but next slide is busier. That's the dental services. So this was in 2024. We were lucky to have on the right side, you'll see some dental chair. We had 4 of them we use for our elderly and for those that are more competent and healthy, then we use just a chair. That is how it is. Next slide. So this is 2025. We are not so lucky, so we don't have a dental chair. So this is how they operated. Our dental services are very good. Some local dentists are also helping. And this on the left side, you'll see she's probably very anxious and she's probably just having dental filling. 90% of our cases are extraction. Some we do some dental filling and some cleaning. Next slide. So the ophthalmology and optometry services are the busiest. They have like 2,000 most of the time. On the left side, you'll see Dr. Burillo, who's a retina specialist from San Francisco, and using a gun, or what we call a Falcon fundus camera. Like, instead of using the fundoscopy, he looks at the retina that way. He brought it in with him. And then on the right side is Matthew, who's using an autorefractor. He's an optician to check the refractive lenses. Next slide. After checking, then somebody gives away reading glasses. We, I think, gave 2,000 of the reading glasses aside from the other glasses too. So it's a little bit cheaper in the Philippines, so we buy it there. It's only around 50 cents per glass, depending on the grade. Here, it's $1 at Walgreens. Okay, next slide, please. And you can see the faces of the patients who are very thankful for a 50 cents reading glass. Then we have the rehab team. We have a chiropractor from Alameda who brought his 2 chairs and is heading the team with some physical therapists and local occupational therapists. Next slide, please. And this is a patient with Down syndrome, 7-year-old, and always being carried by her grandmother. So he was not able to use his feet a lot. Next slide. They're trying to train this, did some stretches. If you see the legs, it's atrophic already. And they were just trying to teach her how to walk again. And these are the other, their cases are mostly stroke patients. That's okay, go ahead. Stroke patients and some myalgia patients. Next slide. Want to show you pharmacy services. We buy by bulk. So if you're an accountant and volunteer, I will put you there because you know how to count pills, right? We put them in smaller packages and then give it to the patients. And it's led by a licensed pharmacist. Next slide, please. All of these units, I have licensed people that should help. This is a mobile unit where they have the X-ray and ultrasound machine and laboratory. So we use them and we just pay them per patient. Like, 100 pesos or 50 cents per reading of an X-ray. So it's not very expensive. We can go a lot for our dollar. Next slide, please. So this is one of my favorite, community health education. I think that it's very important to educate everybody, not just give them dole out medicines, but let them know about this. So we divided our audience to non-healthcare workers and healthcare workers. So I was in the healthcare worker department. Next slide, please. So we had about 350 healthcare workers, medical assistants, midwives, some police officers, some ambulance driver, and on your left side, if you look, those are nursing students. Next slide. I was teaching basic life support, and my partner, who's an intensivist from Kaiser Antioch, is teaching Stop the Bleed. And again, they were all donated by Fremont Bank, and I use them also here locally in the community outreach. So I bring them there, and then I bring them back here because I needed to use them for our community outreach locally. Thank you. Next slide, please. So Gina, who retired this year, is our lead for the minor surgery. On your right side, you'll see a very a large boy that is very, it's not tender, it's so hard, it's actually a gouty tophi. It's from gout, from history. Next slide. I'm just giving you all the different departments, central supply and biomed, that's Dan Dublin. So Dan Dublin or biomed department is very important in a hospital. They're the favorites because his team goes to all the floor to fix the bed, fix the any machine, anything that the ventilators and things like that. So they work hard. So they're a five-man team in our department. Next slide. So these are all the boxes that we sent earlier, about 2 months ago, by ship. And and on the left side, you'll see a concentration of oxygen that was donated by my patient. So I brought it along so that I can also give it to another patient in the Philippines. Next slide, please. And of course, these sutures we buy because the surgeons are very picky. So we buy the sutures and some of the stuff. We buy it here and then bring it home because the quality back home is not as good. And our surgeons, I don't know if Dr. Achanta complains, but it's not as good as what we have here. Okay, next slide, please. This is an old sterile processing unit that I just wanted to show you. Next slide. This is a story of an 8-year-old girl that was diagnosed with ectrodactyly or lobster foot. We discovered her in 2023. We did surgery, micro amputation of all the toes, and then she came back in 2024. We saw her in 2024, now in a rubber shoes, standing beside me. And on her back is Dr. Kevin Miller. He's the podiatrist surgeon from Stanford. So that's one success story at a time. Next slide, please. This is an unfortunate gentleman that had tongue deviation and on further examination had a tumor on the left neck area. And I think it's also invading the neck area, and that's why it's a complicated case, and our surgeons, of course, cannot do it. So we refer them to a higher center. So this is what we do during the process of discussion with the provincial healthcare officer. We tell them that if we can't do this, we need to find a way to send this patient somewhere. And sometimes we also fund these transfers. Next slide. I'm just showing you all the pre-op cases that I saw because I was assigned in the pre-op. I'm everywhere, but mostly in the pre-op cases. It's a big mass, and it was fluctuant with some draining sinuses that keeps on infected. But I called Dr. Loja, is a vascular surgeon from Stanford, and she brought her portable ultrasound. I wanted her to check for cysts or blood vessels and things like that before sending her to surgery. And it was not vascular. There's not a lot of blood vessels, so it was safe to go ahead and take it off. Next slide, please. This is another unfortunate lady who had, I think, scrofula. It's with draining sinus, started with a small lump on the right neck. So this one I sent for culture first for tuberculosis before sending them to the surgeon for excision. And on the right side is a patient with osteomyelitis who had a fractured left lower extremity and then got infected, I think. So we were not able to take care of this patient because he has to be on antibiotics before doing the surgery. And remember, the surgeons volunteer. We cannot choose them. Whoever volunteers, if there's an orthopedic doctor or a general surgeon, those are the kind of services we can do. Next slide, please. This is cleft lip and palate. We did have a plastic surgeon, so took care of it. But on the right side is a big mass on the mouth, and we didn't have an ENT doctor or maxillofacial surgeon. So this is another one where I triaged and sent to the higher center. Next slide, please. And so for the next few interesting cases, Dr. Chanta will go ahead and share it with you.
So
Andy?
this was my domain, so to speak. We had surgeries listed on this board. This lady that you see by the board is the master. She controls traffic, much like our operating room here. But it's a makeshift desk and a makeshift board. We arrive and we look at our assignments. Basically, everybody knows where to go. Our teams are predetermined. Each OR has 2 tables separated by a partition, much like a screen that separates the 2 beds. And as I'm finishing one surgery, the anesthesiologist is putting the patient to sleep on the next bed. And that's how we operate and to increase efficiency. Next slide, please. This is the entrance to the operating room, and just getting ready. Next slide. This is the team that in my room. Veronique, who is a cardiac nurse, Darcy, who worked at Washington for many years and played several roles in the operating room. Darcy was my tech, and Veronique was my nurse, and we did a lot of surgeries. All right, next slide, please. So this, in the first picture that you see a bunch of people sitting in chairs. Some of them are kids with numbers on top on the wall and IVs on IV poles. This is the pre-op holding area. This is our pre-op holding. This is how they bring their own charts. This is biomed, as Carmen mentioned. Every day there was something broken, something needed fixing. This is the anesthesiologist with the biomed. He's on the floor fixing his anesthesia machine before we started. And the last picture you see is Veronique checking her patient in, making sure that even though we are in a medical mission, the goals of the right patient, right surgery, making sure that the documentation, because there is such a language barrier, it's so easy to mistake or misunderstand. So making sure is something that is really, we count on, because as I'm finishing one surgery, I'm going to the next, and that part is prepped and draped. So I'm just operating like with complete trust. So I'm not seeing the patient before. So this is an important part of what we did. Next slide, please. So most of the instrumentation gets sterilized in bins. They get washed, and some of them go back into circulation, and some of them go into sterilization. The second picture I wanted you to see, there is in this particular instance, there were 2 teams operating in the same room, separated by this thin sheet. On the other side, you can see me doing my thing, and on this side, it was the GYN surgeons doing a big ovarian tumor surgery on that particular day. Next slide, please. So this is the kind of cases that we see there, we see and do. You know, when we deal with breast cancer here, we deal with millimeter breast cancers. These are essentially, it's hard to say where the breast is and where the cancer ends. Very, very sad and humbling cases, bulky lymph nodes. I recruited the vascular surgeon that you saw who was recruited to be the ultrasound technician. Everybody becomes everything. We become the technician, we become the pre-op nurse to pre-op screener. Dr. Akawali was the pre-op screener. So it takes a village, and we've treated 49 such patients. My team treated 49 patients in the 4 days that we were able to operate. So that's a lot of surgeries to be doing. You know, it was blistering. Next slide, please. So these are some of the youngest patients. This is syndactyly, the toes are fused. and they've been unfused by this was done by our podiatrist colleagues. Sometimes I would assist because they needed a hand, and so whoever was available jumped in and helped. But you see the beautiful result. Next slide. So this lady, interesting story. Carmen found out that she just delivered a baby and not that long ago, and then suddenly started to develop this. She was under the impression that she was pregnant again, and it was not pregnancy, but it was a very large ovarian tumor. And after the surgery, we have another picture. Next slide, please. That was her after the surgery. She was discharged before we left that place in 5 days. Again, they do so remarkably well. I've not seen a single wound infection there. You see the beds, and they don't even have they don't have sheets on the rubber mattresses, and yet no infections, never. I've not seen one in all these missions. Next slide, please. Deliveries, I can't speak to them, but I've seen so many happy memories. This is one of the happiest places. A lot of people love to volunteer in these areas because they get to play with babies.
Kranti, this is not scheduled. This is urgent deliveries.
Yeah, these are precipitous labor. They don't have time. They just come in labor, and very quickly they are in labor and delivering. Next slide, please. This was our Filipino Medical Association president at that time. He was leading the mission. Like I said, everybody likes to go and hang out with the babies. So these are a couple of our surgeons carrying the babies. Next slide, please. All right, this is an orthopedic surgeon. So you can see these are injuries that happened days, if not even weeks before, and the patients have been sitting on it. And this is one particular patient that Leslie was an orthopedic surgeon. Where was she from, Carmen?
From Stanford.
From Stanford.
And she is particularly
She was incredible, and she fixed this complex comminuted fracture, and the guy was so relieved, and his leg was not shortened anymore, and he was able to ambulate with partial weight bearing by the time we left. Next slide, please. All right, this is the PACU and recovery room. This is, again, Dr. Akawali, after the pre-op, was involved in the PACU and recovery room. Some of our littlest patients after cleft lip surgery, and there's no narcotics available. The only pain medication they have is Tylenol, no matter what surgery you do. And not a single person, even the littlest people, don't complain. They just know how to, I don't know how they do it. I'm mind blown. I get choked up because this kind of stuff is unreal. You can't, it takes you back to that place where how in the world can people put up with that kind of pain and not say a word? Ask every one of them will say, I'm fine. Next slide, please. This is the ICU. Our very first patient that I operated on, was this little guy. We did a hernia operation, and our hotel was 45 minutes away from the hospital. So we made it all the way to the hotel, and at around 11 o'clock at night, I get a call from Athena. Some of you may recognize her. She's in the foreground in front of Carmen in the middle picture, and in the picture to your right. So Athena was our ICU nurse, is our ICU nurse here, and she called me. They called her in the hotel and said, this patient's crashing and coding. So we jumped in a car at 11 p.m. and she doesn't know how to drive in the Philippines. And there we were, myself, Athena, and another person, another doctor. It was actually a pediatrician.
Intensivist, yeah.
We jumped in and we drove. We had to give him blood. He bled into the retroperitoneum, but we were able to resuscitate this kid and bring him out. So he was our first ICU patient and our first complication, if you will. Next slide, please. Yeah, the wards. This is how charts are kept. You make rounds. Most of the patients are in hallways. I wanted you to see this picture on your right-hand side. This is a gentleman who is 36 years old with active TB, intubated, but there is no ventilators. All they have is an ambu bag, and this is his wife in the foreground, and his mother is somewhat covered, and they take turns ambu bagging him in this hallway, and they were there for 4 days. I want to ask, I mean, I asked this question so many times to all of my friends. How many people will bag us for 4 days without a break? It'll be a short list. I'm just mind blown with this kind of stuff. So this gentleman eventually, after 4 days of intubation, got extubated, active TB, and we don't know what happened to him, but he was still in the hospital when we left. Next slide, please. Some of our patients, post-op patients. Next slide, please. Yeah, making rounds. We always have some toys and some eats. The best way you can make friends with these little kids is to give them a bag of chips, and that's all it takes. And this kid is post-op day number 1. After a bleed, after a hernia operation, after a bleed, he scared the living daylights out of all of us, thinking that we were going to lose him. And look at him. He is sitting up, bolt upright after 1 unit of blood, eating chips. I mean, yeah. So next slide, please. Yeah, this is how you would find the volunteers in the bus or in the ante rooms or on a gurney or wherever, just passed out of sheer exhaustion. This is a very familiar scene. The lady who is in the back seat here is Leslie, the orthopedic surgeon from Stanford, passed out for the count. Next slide, please. This is the hospital laundry. Far cry from our sophisticated laundry. They hand wash their laundry and air dry them, and that's how it is. That's the way laundry is processed, including the OR drapes. But the OR drapes, after they're laundered, they're sterilized. That's the only difference. Next slide, please. I think that was it for my part of the presentation. I'll
just
give
very
it back
brief.
to Carmen to finish up on the data and statistics.
We're almost done. The one in the middle is my husband, Arnold. He's part of the statistics team. Next slide, please. So in 2024, we had 7,212 encounters. 246 were surgical, 6,966. I'm not going to go through each of slide because it's busy slides. I'll just summarize it for you. 6,966 outpatient, 80 major surgery, and out of that 80, Dr. Achanta did almost half, or 49 of them. So that's how he worked hard. I really made him work hard. In 2025, because I was sending all my cases to him for pre-op. Okay, so this is cleared, go to Achanta, go to Achanta. And he wanted Dr. Achanta wanted 2 beds, 2 beds, surgical beds for him to do after one is finished, he goes to the other one, but they won't allow him to do that. For 2025, we have more cases, 8,398, and 218 of them were OR or hospital, and 8,180 are outpatient. So we have a lot. Next slide. We do have a lot of surgeries. Next slide. I'm not going to go through them all now, but most of the surgeries are cholecystectomy, thyroidectomy, herniorrhaphy, hysterectomy, cataract surgery. We had 100 in 2024, and they only had 12 this year. Next slide. and just one breast surgery with Dr. Achanta in 2024. In the outpatient world, optometry had 1,928 encounters in 2024 and 2,243 in 2025. Dental is about 1,400. So they have a lot. Next slide, please. I think we're almost done. Some more until the next slide. Okay, so time to go. That's our container. And we put all our anesthesia machine and all the heavy equipments. We put it all there and then leave it with the host for 1 year until the next mission again. Next slide. And that's it. And we thank Washington Health a lot, Foundation, and all the stuff. Kimberly, thank you very much for supporting the mission and giving us an opportunity and donating,
Yeah.
whatever you don't need anymore.
Yeah, I echo Dr. Akawali, and I cannot tell you that every piece, every suture, every Band-Aid is accounted for and used appropriately. Not a single thing is wasted. So all of these efforts are only possible because of Carmen's energy. I wonder what will happen to this organization when she leaves. But as long as she's there, I will go with her and support her on these missions. And I thank you for the time and for listening to us.
Thank you.
Thank you.
Thank you, Dr. Akawali and Dr. Achanta. Any questions or comments from board members?
No, good job.
Thank you so much. It's wonderful work that you do.
You want to go? Yeah.
Can't say enough. Thank you.
Thank you.
Okay.
Thank you.
Thank you.
Okay, we're going to move on to the medical staff report with Dr. Sela.
Hi, everybody.
Yeah,
Good
he's on.
evening. Yeah, these types of presentations are such a hard act to follow. Bravo to Carmen and Kranti and the whole team for such an amazing mission and all that they do. At one point during that presentation, I thought I heard somebody in the boardroom rumble about maybe using teleradiology in the Philippines. 50 cents a read. Just put it out there. We'll even pay them $1 a read. We'll double their rates. So let's start off with the medical staff census. We have 365 active staff, 2 administrative, 37 advanced practice providers, 98 ambulatory, 9 consulting, 11 courtesy, 1 leave of absence, and then several provisional active advanced practice providers, consulting, and temporary privileges. Grand total of 664. In terms of announcements, the big one is that the elections start next week for the various leadership positions in the medical staff. So the ballots will go out the week of April 14th, and then we'll be due soon after that, and then we'll have the final tally and the final positions finalized. Doctor's Day luncheon was March 31st, and it was a big hit. We had a good turnout, and I think everybody enjoyed the food, and thanks to everybody that participated in setting that up. The dinner dance, the semi-annual one, is coming up on June 28th. When we first started talking about that, I thought that was so far away, and it's now coming up so fast. I'm going to be honoring Dr. Erasmus for that. Final thing I think is the other thing to mention is aquablation is going strong. I did 3 cases in the past week, including 2 this morning, and everybody's doing very well. The patients are been very happy with those procedures. And one of the patients I did today came in from the Sierra Nevada area, from the foothills, traveling there, and the other one actually was from the Central Valley. So the word is getting out there that we're doing this, and people are coming for it and asking for it. Specifically, so it's a great program. I think that's all I had, unless anybody has any questions.
Questions, anyone? Okay, well, thank you, Doctor. Thank you. Appreciate it.
Thank you.
Thanks, everybody. Have a good evening.
Good. Thank you. Okay, Sheila, you're up with the service week report.
Hello and good evening, members of the district board. A warm greetings from all the volunteers. I want to begin my report by expressing our heartfelt thanks to Washington Health for hosting such a wonderful volunteer appreciation event yesterday. We really felt truly celebrated. The food was delicious, the entertainment was wonderful, and the warm atmosphere made everyone feel special. It means a lot to us to be recognized in such a thoughtful way, and we feel so fortunate to be part of a community that values its volunteers. Once again, a big thank you to all of you on the district board and everyone at Washington Health. So thank you very much. Moving on to my report, in March, 232 Service League volunteers contributed a total of 2,152 hours across various hospital departments. The Service League has begun focusing on recruiting additional wolf canine therapy teams this year. As part of this effort, the wolf lead trainer, Russ Weinberg, developed a series of educational talks that we offer to dog owners. The first of these presentations occurred on March 14th with an engaging session focused on recognizing stress and anxiety in dogs. So it's not just us, it's dogs too, I believe, and keeping them healthy and happy. About a dozen attendees joined on Zoom and showed great interest in the topics covered by the guest veterinarian. We look forward to continued engagement with the community and hope this initiative encourages more people to explore opportunities available through our canine therapy program. On March 16th, we hosted an information session for potential nurse unit assistant trainers, followed by an orientation session on April 5th. Our NUA volunteers assist nurses by answering call lights and responding to patient requests, among other duties. The information session are designed to nurture future leaders in the healthcare industry while strengthening the foundation of our volunteer program. By engaging volunteers in this way, we not only enhance our service efforts, but also foster mentorship, leadership, and growth within the hospital community. And lastly, I'd like to highlight the upcoming $5 masquerade sale on April 28, 29, and 30. Larry likes that. I saw him nodding. So I'll see you there, Larry. This event will feature a wide variety at bargain prices, providing an opportunity to support our hospital while enjoying great deals. We encourage everyone to attend and share the event details with friends and family to maximize participation. Thank you all. That concludes my report. Let me know if you have any questions.
Thank you, Sheila.
Thank you.
Any questions? Okay, well, thank you very much, Sheila. Have a good evening. Thank you.
Thank you. You too. Thank you.
Okay.
All right, our next report is our annual antimicrobial stewardship program update, and we are pleased to have come sit down, Dr. Diane Martin here in person to join us. So I will do a quick introduction for you. Dr. Diane, though I think many of us know you, worked as a member of Washington Hospital's medical staff from 1984 to 2023. Dr. Martin has served in many leadership roles at Washington, including chairperson of the Department of Medicine and chairperson of the Clinical Evaluation Committee, which includes pharmacy, therapeutics, and infection prevention. Since retiring from the Washington Township Medical Foundation in 2023, she still remains very busy with working at the health system. She has continued her role as the infectious disease program consultant, and she is currently the chairperson for the Antimicrobial Stewardship Committee, as well as the chairperson for the Infection Prevention Committee. She's also, of course, as we know, served as one of our key leaders during the peak of COVID response planning, a role she continues today. So, turn it over to you, Dr. Martin.
Thank you. So I want to go over their antimicrobial stewardship program, and this is an annual report. And the primary team members are Mintu Denon, who is Director of Pharmacy, and also Cindy Lau, who is a PharmD, and without them, I wouldn't be able to function. Next slide. So the antimicrobial stewardship has several goals. We want to promote the appropriate use of antimicrobials. We want to slow down resistance. We want to prevent the spread of infections caused by resistant organisms and reduce adverse effects of antibiotics, and in the long run also decrease hospital costs to both patients and our system and decrease length of stay. Next slide. So why do we need antimicrobial stewardship? There are fewer and fewer antimicrobials being developed, and as we're seeing increasing resistance, we have less opportunities for improvement. We want to promote responsible management of antimicrobial agents. We want to promote optimal use of antimicrobial agency so that we can get that outcome with minimal side effects and reduce long-term resistance. We worked with several other entities to kind of help do this, and without that teamwork, this wouldn't be possible. And that includes the labs, nursing, and infection control program. Next slide. So antimicrobial usage is something we look at. It's a very critical part of modern medication, whether it's inpatient or outpatient. In terms of patients, we see those that have chemotherapy, transplant, and dialysis, whose immune systems are very much suppressed, and they're much more susceptible to infections and need the antimicrobials. Sepsis is something that we see from time to time. It can lead to organ failure, both kidney and liver, so we want to prevent that as much as possible and treat it appropriately. Many surgeries we see today would not be possible without the use of antibiotics. We also see chronic conditions, liver conditions, renal failure, and those are much more susceptible to infections and need antibiotics. Next slide. So talking a little bit about antimicrobial resistance. So antimicrobials can save lives, but also trigger bacteria. Bacteria are very educable. They learn what's knocking them out, and so they mutate or change to accommodate. So antimicrobial resistance comes when the bacteria develop mechanisms to defeat the antimicrobials, which are designed to eradicate them. This is a global challenge, so not just U.S., it's a global challenge to modern medicine. The resistance can develop quite quickly. We've seen that with both COVID, also TB, syphilis, and influenza. So there are resistant organisms which would benefit if we were able to improve our antibiotic use. So this is my team who I'm very proud of. So it's multidisciplinary. Medical staff includes both hospitalists, intensivists, and other parameters. We have several of the ID physicians maintaining on our system. Nursing is very critical. Tigas and some of the others participate and give us perspective. Sometimes I look at things from one angle and I need them to sort of keep beyond the course. Pharmacy, we have Min2 and also Cindy Lau, laboratory, mostly Raj, who works in the micro department, which helps quite a bit there. We have IT ad hoc, who are very receptive to helping us, looking how to program things, how to look at things. Compliance is very helpful. Infection prevention, and like I said, Min2, as our director of pharmacy, is very instrumental in keeping this team up and running. Next slide. So these are some of our accomplishments. We do an annual review of the antibiogram, which does change quite often. So we sometimes see bacteria that were very rare and now have more frequent, so we include that on the antibiogram. We see some susceptibilities which actually get better and some get worse. So those are also highlighted in our antibiogram. We do a systematic utilization review and resistance trends so we can see where we are in terms of appropriate antibiotics. We update treatment guidelines to try to improve antibiotic use. This would be like in chemo patients, dialysis patients, renal patients which might need certain parameters changed for them. We do quality improvements. We try to identify areas that need improvement, and that's coming up in the next couple slides. We also do improvements to improve our outcome in the long term. Next slide. So we have treatment guidelines which we use. These are not mandated, but they are there for the physician to use. And we incorporate best practices from both Joint Commission, CDC, NIH, National Institutes of Health, as well as IDSA, which is the Infectious Disease Society Association. We try to optimize. In other words, the more we do it appropriately, the less resistance and the better outcomes for our patients and reduced costs. So we have order sets which are empiric. In other words, if I'm seeing somebody, I'm not sure what the issues are, I have an empiric order set that I can use. These are optional. If I want to trend to something else, I can. But these look at what we tend to see in terms of our resistance patterns and what are currently recommended for specific infections. The same orders are also embedded in ED, because ED is so fast and sees so much stuff. We try to promote order sets that help them move quickly through treating the patient, getting them started on medications, hopefully shorter hospital. We have an ID consultation for specific antibiotics. These are ones that are used very specifically and can produce resistance. So some of these we encourage and almost mandate that the IDs see these patients and at least give guidance to the primary care physicians and our hospitalists and intensivists. We do an annual antibiogram, as I mentioned, and it basically shows our local susceptibilities. We can also look at CDC and other areas to see what trends are across the country. We'd like to see what we're dealing with our specific patients. Next slide. So we participate in NHSN, which is National Healthcare Safety Network, which helps us track utilization as well as resistance and looking at our specific data for Washington Hospital. We have a stewardship team which reviews this and tries to make opportunities for improvement. And we're constantly giving feedback both to the hospitalists, the intensivists, the nursing, and the departments. We talk at different department meetings as well as general staff meetings. Next slide. This is a little bit busy, but what we're looking at is antimicrobial usage trend, and this is across the nation. Almost all hospitals look at exactly this type of data. And the idea is to keep the ratio at 1 or below. So worse than 1, above 1, you're worse, lower than 1, you're better, 1, you're as expected. So you can see, looking from July of 22, we started off pretty well. We kind of went back up, and in December, we're headed trending back down. We're definitely making improvements. We get our data quarterly, which is why I don't have anything for January, February. Next time, maybe. Next slide. So what we did was also not to just look at the antibiotics across the board, but to look at specific ones. And I'll go into this in more detail with the next slide. But what we're looking at is this is broad spectrum, which is one, if I see a patient, they look very sick, I'm not sure what's going on, this would be my go-to drug, which is Piptazo, which we also use meropenem and cefepime. The gram-positive is more like for your staph and your strep, which would be vancomycin, daptomycin, linezolid, and then the antifungals and dulafungan and fluconazole. So again, the idea is to try to keep our antibiotic appropriate use, try to see if we can standardize ourselves against other entities, and the idea is to get it under 1. So you can see we trended down in our last quarter. Again, we were able to hit that goal. Next slide. So we're doing continuous quality improvement. We look at our medication use and we analyze it to see where we might be able to make some improvements and identify areas that can be improved. So right drug for the right bug for the right duration. We implement guidelines, and again, these are suggestions for the physicians. They're not mandated, but we do think that they make an improvement. We also have order sets that incorporate antibiotics. We have protocols. We also use EPIC workflows to sort of optimize our antimicrobial use. So the pharmacists on the floors can see this and can reach out and make recommendations to the primary or the intensivist or the hospitalist to see the patient. We're constantly doing evaluation and figuring out what's our challenges and how to work through that. We're modified workflows, guideline sets, order sets, and protocols. Because what we want to do is provide best care for our patients, and some of these are actually life-saving treatments. Next slide. This is a little bit about quality improvements. So we designed for the ED a treatment algorithm. So when they're looking at a condition, what's the most likely antibiotic to use? The patient presents with a minor skin infection versus more serious versus devastating, needs to be in the hospital, might need surgery. So we have them ranked by acuteness of the illness, and that's primarily for ED. We're looking at to also work on the units, but that's work in progress still. The novel antibiotics are the ones that are used for a very specific condition. And what we're doing is trying to improve the use of that, because overuse, when it's not appropriate, triggers resistance. So what we're doing is looking to see where we can improve on that. We have C. diff, which is Clostridium difficile, which is a bacteria that's commonly found in our intestinal system. When you take antibiotics, they don't know the difference between the good guys and the bad guys. they knock out them all. The one who's most resistant is the C. diff, which then results in a horrible diarrhea, abdominal pain, can need IV fluids and management. So what we're doing is looking at our C. diff algorithm to try to prevent any of that, which would cause unnecessary treatment, and we're educating our staff as we're going through. And again, we're trying to educate not all cases of diarrhea are C. diff, so we have to appropriately check and treat. We're also educating our staff on laboratory tests that can help them determine when an antibiotic is needed. The procalcitonin is something you can measure. A really high level would indicate a bacterial infection versus viral. MRSA, which is methicillin-resistant Staph aureus, the PCR tells us specifically we're looking at an MRSA infection. Because when the patient first comes in, we first get a blood culture, it shows staph, we don't know which one we're dealing with. With MRSA PCR, we can say, this is Staph aureus, this is not Staph aureus. Because then we're looking at using vancomycin for Staph aureus, and the more we use, the more resistance we see. So if we can appropriately use it for specific indications, the longer we can keep our antibiotics and keep everybody healthy. We collaborate with the pharmacy. So one of the couple of programs that we've looked on is IV to PO. So IV is intravenous antibiotics. When the patient comes in, most of the times they're on intravenous. As they're improving and they can tolerate oral antibiotics and they're appropriate based on the sensitivities that we're seeing from the lab, we can switch to oral antibiotics, which helps patients transition to home faster, reduces IVs, which in and of themselves can also cause infections and tend to prolong hospital stay. We collaborate with the medical staff to use the empiric order set and microbials very upfront, because we can sort of give the guidance as to what antibiotics are going to be most useful, and also when to do the step down when we get results. We also do renal dosing, because patients who are on dialysis or have severe renal function, their metabolism is affected and they tolerate the antibiotics in a different way. So we can cut down on the dose for those for liver, kidney, and that's what we look at. And again, the pharmacy is a huge, huge part of that. We also collaborate with microbiology. We have an annual antibiogram, as I mentioned, comes out, and it gives directions for what you think might be the most common infection and what we see in our hospital as most effective antibiotic treatment. We also do antimicrobial susceptibility testing, and we see sometimes the bacteria get more resistant, so we have breakpoint where this drug will be effective or not effective, and that we put into our reports. We also can do virologic testing, because this helps you when you're looking at somebody with a respiratory infection coming in, coughing, short of breath, a lot of mucus, chest x-ray looks bad. We can see, okay, is this viral or not by doing a PCR test. So it helps us quite a bit to try to determine, do we need an antiviral infection or do we need an antibacterial? So they could have like COVID, influenza, RSV, or bacterial infection. It kind of helps steer your decisions. Unfortunately, we do see a lot of blood culture contamination. When we're drawing blood cultures, sometimes if we're not very, very careful with skin cleaning, you're going to contaminate the culture. So then we're looking at, is this real or not real? So we've been working very carefully with ED department as well as ICU, because they do a lot of this, to try to make sure that we use appropriate cleaning techniques and therefore hopefully reduce the incidence of blood culture contamination. Right? So a huge part of what we do is the role of infection prevention as well. And we have a new infection preventionist for which I'm extremely excited. So you will all meet her at some point, but she is very good. We have a second coming probably in a couple months as well. So what we do is review hospital-acquired infections and try to figure out what's the best action plan for them. One example was we were seeing a lot of staph, and so we implemented chlorhexidine baths as well as nasal decolonization to reduce colonization of MRSA. So the less we have MRSA, the less resistance we have, the better the patients get to go. We're also monitoring trends of resistant organisms, like I showed on our antibiogram, but also we do that on with that other SAR rate, we're also monitoring with that. And again, we're trying to strongly encourage appropriate collections for C. diff, because again, not all diarrhea means C. diff. And we try to get it early on in the hospitalization so we can induce changes and also appropriate antibiotics. Next slide. So the other thing we try to do is reach out to the physicians and try to include them in what we're doing. So we're doing frequent reports on utilization and resistance. We present to general medical staff, medicine department, family medicine department, and surgery department, and other subcommittees, pharmacy and therapeutics, and the clinical evaluation committee, to try to get this information out there. We share process improvement analysis and opportunities to optimize antibiotics with the medical staff through the same information. We also have an online education for the nurses and the pharmacists, which is one way of trying to get their system, which is usually so busy, they can flex it and accommodate their schedule to look at these online. That is my last slide, and I will take any questions. Okay, thank you.
Yeah, I always-
Your turn.
So my question, Diane, is reducing our patients' exposure to antibiotics, and obviously that's what the whole core of antibiotic
Or the
stewardship.
high-level antibiotics.
Yeah.
Those are the ones, if we get resistance, we don't have another one.
Right.
So if we can de-escalate or
Yeah.
shorten course,
So that's my question. So, what technology is available to allow us to more quickly identify causative organism and the sensitivities so that we can do the de-escalation? And then what kind of technology do we have so that we can better determine what is the optimal course? How many days of exposure to antibiotics does a patient need?
yes.
How do we eliminate unnecessary days of antibiotic exposure?
So going back to the first question,
Mhm.
most of the times what we start out with is doing an antibiotic course based on what we think the problem is, a pulmonary infection, a renal infection, a systemic infection, sepsis. And basically the first 72 hours, we're pretty much doing full court press.
Mhm.
Unless we're looking at those viral parameters and we can tell, okay, this is a viral pneumonia, you don't need the antibiotic.
The PCR panel for respiratory has just been a revolution.
Yes,
It's
yes.
just made a world of difference. It's kind of opened our eyes as to all the different viral infections that we're seeing.
Mm-hmm.
So we look at the first 72 hours or 3 days as basically the window where we will accommodate whatever the physician thinks is best practices.
Mhm.
After that, we should be able to get the sensitivities and then de-escalate.
Mhm.
And the pharmacists on the floor work very closely, especially our hospitalists. They are very receptive.
Mhm.
The intensivists are also very receptive, and the pharmacists work with them to say, well, you've got this patient on vancomycin, but we don't have MRSA, could we
Yeah.
de-escalate? So that's what we try to do. The other thing you brought up is length of therapy.
Right.
This is a very hot topic right now.
Mhm.
There was a recent New England Journal article that talks about bloodstream infections, which we've traditionally always done with 2 weeks,
Yeah.
now down to 1 week. So our team is looking at that right now, and it's very exciting.
Mhm.
So hopefully we can implement that. But we have this sort of, the pharmacists will work with the intensivists in the hospitals after that 72-hour window. We've got the sensitivities, the patient's getting better. Can we de-escalate?
Yeah.
Can we switch to PO, which would get the patient home sooner?
What can we do to reduce that 72-hour period?
Other than the PCR, we're basically almost always waiting for what the results are. It takes about that long.
It's the traditional culture
Yes,
method.
pretty much. And I think squeezing that window would be very difficult. There may be something new coming up.
That's why I'm asking.
I haven't seen anything yet.
Wishful thinking
Yeah,
on my part, yeah. Mhm.
So the PCR basically is our best goal right now, especially being able to say, this patient has a viral infection, does not need
Yeah.
fluconazole. Does not need
Need it.
Pip-Tazo or something
Mhm.
like that. I mean, that's been our biggest change. Acceptance has also been a little slow.
Yeah.
So we're always out there rooting.
Yeah. When was that New England Journal article on the blood cultures, on the
I think it was
bacteremia?
like first or second week of April. It's
Okay, so very recent.
It's very, very
Probably in
recent.
my stack.
Yeah.
Okay. All right.
So I think, that's something that our team wants to look at
Uh-huh.
and evaluate. We'll work with the pharmacist on that, work with the hospitalist, the intensivist on that, and kind of see.
Yeah.
And a lot of it
That's
depends
very
on the
promising.
comorbidities of the patient. If you see somebody who's in-stage renal disease, they might not be susceptible receptive to changing antibodies to say somebody who, you know, is otherwise healthy. Was in the wrong place.
Thank you, Diane.
Wonderful.
Thank you.
Thank you very
Very
much.
good.
Thank you.
very much.
Keep up the good work.
Good team, too.
Yeah.
Great
Yeah,
collaboration.
I could not do it without the team. Our ID docs come to these meetings, they don't get paid.
Mhm.
I mean, that's easily an hour out of their time. The pharmacists have been so organized and so coordinated. I mean, you have a team you would not believe.
Good team.
Yeah. So there is actually, off the record, we're going to try to apply for what's called the honor roll, which is something you have to look at each of your programs to see where you meet up, and they have a gold, a silver, and a bronze. Eden has it, St. Rose has it, Kaiser has it, Oakland has it. We want it.
Go for it.
This is what we're working on next, so it's gonna take a lot of coordination to
Yeah.
get there, but we think we're working.
Oh, yeah.
Good
Good job.
Good work.
Thank
That's
you.
great.
Thank you.
Thank you.
Thank you for your leadership.
Okay, so then, go to the finance.
All right, we're gonna start with Ajay. He's going to present the February financials, and then I will follow by the March.
Thank you, Kimberly. I think overall, the month of February was a little to below budget in most of our operating indicators, and you'll see that our financial indicators sort of followed that. Year-to-date basis, we're still fairly strong in a lot of our indicators, and just quickly going over this, daily census was, for the month, was almost right on track, although on the year-to-date basis, we're a little down. Discharges, we were down 9, year-to-date basis, roughly about 200. Patient days, almost right on budget, but year-to-date, we're about 2,000 plus down. Length of stay is actually a good story. We're running behind budget, and I think that will carry on as you see that. And year-to-date, we're similar. Moving on to the next slide. The next set of operating indicators, case mix index has been strong this month and on a year-to-date basis. Deliveries also strong this month as well as year-to-date. Surgical cases, although this month we were below budget, year-to-date we're above budget, so that's great. Cath lab cases has been down on both for the month as well as the year-to-date. Outpatient visits, again, strong on the year-to-date. We've done well, but for the month, we were below budget. And ED visits, 243 below budget, and 664 for the year-to-date. On the surgical and cath lab indicators, our surgical cases were 23 below. Mostly, as you can see, there was variations. Orthopedics, we did pretty good. Vascular, not so much. And I think there might be some other types of, the way that we're counting this is changing a little bit, so that's probably attributing that from there. Cath lab cases were also below budget. Majority of them were coming out of the peripheral vascular program. And on a year-to-date basis, same story. We're below budget, but coming out of the peripheral vascular program. On our FTEs, we've done well. Our total FTEs, 112 below budget, and productive FTEs, we're flexing well based on volume. Moving on to the dollars and cents on our revenue. For the month, we were almost dead on our total deductions as a percentage of revenue at 77.4%. Our gross patient revenue was higher than budget. Same story for across the year. We've been about $30 million plus over the year. And on a year-to-date basis, our deductions are also pretty close to budget, 77.5 versus 77.1. Moving on to our operations report, So that that gross revenue translated to about $52.6 million of net operating revenue, which is about $1 million over our budget. And for the year now, we're almost right on budget. We're $300,000 over budget. Our operating expenses, we were higher than budget by about $2 million, and what that resulted in was a net income of just about break even, $21,000 versus a budget of about $900,000. Year-to-date basis, we have a net loss of $1.2 million against a budget of $3.3 million. As you go down here, you'll see our non-operating income was $2.4 million versus budget of $944,000, resulting in a net income for the month of $2.4 million versus a budget of $1.8 million. That's great, 4.7% versus 3.6%. Same story on the year-to-date basis. We have a net income of $18.1 million versus a budget of $10.6 million, so we are about $77.5 million higher budget.
FASB. Yeah.
Move that to the top.
Yeah.
That
There.
top screen share.
You may
Yeah.
go to the last one. Yes, there you go, sorry.
No.
You put the bar up. The
Maybe
black bar is in the
Yeah,
way.
you can't read the bottom
see it.
number.
Yeah, can you get rid of the black bar? Yeah.
Paul wants to know
Drag
our
it down.
dollars. Drag it up.
I know.
There you go.
There, thank you.
There we go.
Thank you. We can't see the bottom.
And this is all gassy, let's see FASB.
Yeah, and the FASB, similarly, it's just geography changes.
Right.
We're at, our margin is 0.3% versus budget of 2.9%. On the last one, the last slide here is our EBITDA slide, which I think tells a really good story, especially when we compare it to last year. What I'll point out is our EBITDA of $27.1 million against a budget of $31 million. Yeah, we are a little bit behind. Last year at this time, we were at $18.5 million. So we're trending the right way. We're making great progress. And on the net income margin, similar story. We are showing a net income of $18.1 million here on the year-to-date basis, as you can see. Fiscal year 24, we were at $2.3 million. So really good progress. Although, yeah, we're in some of these metrics, we may be behind budget, but we're doing really well. That concludes my remarks, and unless you have some questions.
Any questions? All right, let's begin with the preliminary operations report for March. I want to start, next slide. I want to start by talking a little bit about our outpatient observation days. I think many of you know we've talked about this in terms of looking at benchmarks at the state level, that we have been high in terms of our observation days. And so we have been looking at initiatives and kicked off one on March 3rd, basically working Mary Boron, our Chief Quality Officer, working with Dr. Raja Sadiq, who is the Medical Director of Sound Physicians and has worked as a physician advisor in other hospitals, who really has focused on observation patients and really making sure from the very beginning we, as much as possible, get the patient in the right level of care to begin with as they're in the emergency room and if they need to be admitted. So this initiative started on March 3rd, and you can see that the days for this month have dropped significantly from a rolling 12-month average of 348.37 observation days to 159.46. Now, this is just the first month. We understand that 1 month does not make a trend. We've talked about that as a team, but it is in terms of really looking at it. I do want to say it's a multidisciplinary team involving all aspects of the healthcare system. But there is a team that meets basically twice or more times a day to look at the patients and those that need to be admitted, to see in terms of whether they can be admitted directly into inpatient if they meet the criteria. And Dr. Sadiq works with the admitting physician. This is a decision ultimately that is the admitting physician's decision, but looking at all of the labs and everything, the whole picture of the patient that they talk together about the patient. So really looking at increasing our direct inpatient admissions and reducing the OBS conversions, lowering the OBS to inpatient conversion rate, reducing the average observation stay to 24 hours. We have been higher than that. So really, again, continuing to follow through. Also decreasing denial rates and improving overturns through peer-to-peer. So if there are questions that the insurance companies have, the way that happens, there is a peer-to-peer discussion about that, and Dr. Sadiq does that directly with the medical director on the insurance company side. So it's been very successful in terms of that. Now, we're also, there's a lot of systems issues that we determine too in terms of having to wait for certain tests or all that. So again, there's a lot of work that's being done throughout the healthcare system in terms of it. Now, I start with this because it's impacting all of our other metrics that you will see this month in terms of it. And from the net revenue perspective, Ajay and I and the team have talked quite a bit about this, and I think we all know inpatient charges have a lower contractual adjustment percentage, so ultimately it should result in higher net patient revenue. This is something that finance team is continuing to take a look at and to follow. It may not be immediately visible because it takes time in terms of the billing and all of that, but what we are doing is really trying to get more into a normal benchmark around the observation days and the number of patients in inpatients versus observations. So I just wanted to start with that. So then from there, why don't we go on and take a look? Or Ajay, anything else you want to add from that standpoint?
No, I'll just add that I think you're coming back to what the mean is.
Yeah.
I think we were way over here. I don't think we've come here. I think we've actually come to the middle, which is where we need to be. Because, as you know, Medicare looks at this. A lot of folks look very carefully around observation. So and the team, I think, is doing a great job in making sure that the right patients are being attributed to the right place. So this will definitely have a fairly positive impact for the rest of this.
All right, looking at our total gross revenue, patient gross revenue of $232.8 million for March was favorable to the budget of $228.6 million by $4.2 million or 1.8%, and favorable compared to March 2024 by $19.6 million or 9.2%. And year-to-date, you can see revenue was favorable to the budget by $34.3 million or 1.7%. Moving on to our trauma cases, they came in at 173 for March, which was favorable to the budget of 117 by 56 or 47.9%. Year-to-date, we continue to be favorable to the budget by 40%. Inpatient trauma cases of 62 for March was unfavorable to the budget. We continue to see that of 74, or the budget was 74, and so it was unfavorable by 16.2%. And outpatient trauma cases of 111 for March were favorable to the budget of 43 by 158%. Next, you can see the trauma cases broken down by activation code. You can see for the month of March, we had 12 alphas, 42 bravos, and 119 deltas. And again, year-to-date, you can see the breakdown. The three on the right-hand side, the no notification, they did not have a pre-service notification. And again, once again, in March, out of the 173, we had 66 falls, which was the highest in terms of number of types of cases for that month, followed by motor vehicle crashes.
Can we get more breakdown on the type and mechanism of falls? I think that'll be important as far as reaching out to the public.
Yes.
As far as what they should and should not be doing.
Absolutely, and you'll see in the education side, there's a lot in terms of balance classes. We're working with some of the
Yes.
senior centers
Right.
on the balance classes.
Yeah.
I know part of really, and I know we do have it broken down more specifically, because that really, part of being a trauma center is doing that education to
Right.
try to reduce the number of traumas that we see from that
If you're on
side
your
of it.
scooter, wear your helmet.
Absolutely, we're giving out helmets, I know, Terry, if there's anything else,
E-bikes too.
yeah.
Yeah.
Yeah,
Right.
and like Kimberly said, the matter of balance classes are a big deal. So most of the falls are literally ground level falls, older people, hip fractures and things like that. So rather than, the scooter falls, those are actually being classified differently. But we do have this broken down and we can bring it.
That would be
It's
nice.
deep. We have slices of everything.
Yeah.
So yes, but it's typically hitting senior centers, teaching things about rugs and things like that in the homes.
Eliminate those
Using
areas.
proper, equipment. That's what we're seeing a lot of, which is normal across the country.
All right, moving on to trauma gross revenue, you can see the gross revenue came in at $18.3 million for March, which was favorable to the budget of $14.9 million by $3.5 million or 23.4%. Our inpatient trauma gross revenue of $13 million for March was consistent to the budget of $13.1 million. And outpatient trauma gross revenue of $5.2 million was favorable to the budget of $1.8 million. Moving on to our inpatient gross revenue, this is where you will see the impact of the work that's been done on observation days. So inpatient gross revenue of $146.4 million was favorable to the budget by $12 million or 8.9%. This is the highest record you can see in terms of the inpatient gross revenue over the last 13 months. And really, it's attributable to the lower observation days. And $20.4 million or 16 and it's higher than from, if you look back at March, which came in at $126 million for 2024. Year-to-date gross revenue was favorable to the budget by $17.2 million or 1.5%. Moving on to outpatient gross revenue, again, observation in the past has been, you see that in the outpatient gross revenue. So outpatient gross revenue of $86.4 million was unfavorable to the budget by $7.8 million or 8.3%, and pretty much consistent with March of 2024. I do want to say, in terms of the consistent, looking at anything 1% above and 1% below is being named as consistent at this point. So year-to-date revenue was favorable to the budget by $17.5 million or 2.2%. Looking at the average length of stay, also average length of stay for the month of March is 5.05 and was favorable to the budget of 5.47, driven by lower observation days, and was favorable to March of 2024 by 0.15 or 2.9%. Average daily census for the inpatient came in at 187.2, was favorable to the budget of 177.2 by 10 or 5.6%, and favorable to March of 2024 average daily census of 168.7 by 18.5 equivalent days. Again, discharges, March discharges of 1,118 were favorable to the budget of 1,005 by 113 or 11.2%. Again, in terms of seeing due to lower observation days that impacted it, and higher inpatient volume. Year-to-date discharges were consistent to the budget by 80, about 0.9%. We had 8 patients that did stay over 30 days at the end of March.
Just point out, I think this is the highest for this 13 months.
Yeah, exactly. You take a look at that, yep. And really, the patients that we're seeing in-house now over those 30 days are really medically necessary. The majority of them are medically necessary to be in. Patient day trends, again, this is also impacted by less observation days and more inpatient. You can see that came in at 5,804, which were favorable to the budget by budget of 5,494 by 310 days or 5.6%. again, due to the lower observation days, and we're 574 days, or 11% favorable to March 2024. In terms of just adult med-surg days, they were over budget. ICU days, also over budget. Telemetry days were down by 2.3%. And also just in terms of OB and special care nursery, it was unfavorable to budget. Moving on to surgical trend, you can see total surgeries in March came in at 519. This was unfavorable to the budget of 547 by 28 or 5.1%, but was 43 or 9% favorable in comparison to March of 2024. We had inpatient surgeries of 258 were consistent to the budget, so they were down they were actually unfavorable to the budget at 2.3%. Outpatient surgeries at 261 were unfavorable to the budget by 7.8%, and 5.1% unfavorable to March of 2024. This is the breakdown in terms of the surgical activity. You can see with orthopedics, we're pretty much on. With gastroenterology, we're up 8. In terms of general, this is general surgery, but this also includes other cases such as thoracic too. So that is not only general surgery, but also thoracic. We have, if in the past, general surgery had been included in others, so we're trying to break that out more in terms of taking a look. Neurosurgery was down by 8 cases. Urology was down by 9 cases. And then also other was down by 15 cases. And some of that is driven by ENT and GYN cases too. And that's included in other. Looking at cath lab, March cath lab cases of 212. They were favorable to the budget by 19 or 9.8%, and were 26 or 14% more than March of 2024. Year-to-date cases were unfavorable to the budget by 56 or 3.1%, but favorable to last year-to-date by 12%. Looking at it broken down by inpatient and outpatient, inpatient cases of 129 were favorable to the budget by 21 or 19.4%. And cath lab outpatient cases of 83 were unfavorable to the budget by 2 cases or 2.4%. So this month we saw more inpatients than outpatients. Looking at it broken down by cath lab activity, you can see cardiac was above budget by 7. Interventional radiology, which was driving the majority of the inpatient cases, given they were inpatients that needed IR services, was up by 18. Neuro was pretty consistent, just up by 1, and then vascular was down by 7 cases. Moving on to deliveries, we continue to have a busy month with deliveries. March came in at 145, which was favorable to the budget by 5, or 3.6%, and 11 or 8.2% favorable to March 2024. Year-to-date, deliveries were favorable to the budget by 95 or 8.3%. Also, continue our work in looking at C-sections. You can see that it came in for the month at 25.5%. Next, looking at the non-emergency department outpatient trends. The visits of 9,202 were consistent to the budget by 85 or 0.9%, and favorable to March of 2024 by 456 or 5.2%. Those areas that were coming had a favorable performance. In cardiac rehab, we saw were over budget, or actuals was over budget by 153 or 19%. X-ray was over budget, and short stay was also over budget. Below budget was lab visits and also pulmonary. As we know, we did close that outpatient side of things. Looking at the emergency department visits, they came in at 5,190. It was unfavorable to the budget by 448, or 7.9%, but favorable to March of 2024 by 1.8%. We continue to see less than what we have budgeted in terms of the sort of the minimum levels, the level 1, the basic, and see much more higher numbers in our complex cases, so level 4, level 5, and level 6 in trauma cases. So we're seeing less of the basic ED visits and more of the complex, and you'll see that also in the gross revenue for that department too. Looking at the breakdown by gross revenue by areas, you can see surgical services revenue was unfavorable to the budget by $3.5 million or 8.5%. As mentioned, cases were unfavorable to the budget by 5.1%, and also this is driven by the types of cases that we saw. Cath lab services were gross revenue was above budget by 5.7%. You can see room and board by 2.4%, birthing center by 14.8%. Again, emergency department, as we talked about, came in the visits less than budget, but came in terms of gross revenue above budget by 15.9%, basically seeing more complex cases through the emergency room. And lastly, ancillary services was above budget and gross revenue by 2.4%. Moving on to the payer mix for the month. Overall, government payers were favorable compared to the budget. It came in at 73.5%. Breakdown, Medicare was favorable to the budget. Medi-Cal was unfavorable to the budget. It came in at 21.7% compared to a budget of 20.5%. Our HMO was favorable to the budget, coming in at 2.8%. PPO was slightly unfavorable to the budget, coming in at 20.3% versus a budget of 21%. We did see more self-pay. The percentage was 2.7%, and TRICARE was pretty close to budget. Overall, in terms of productivity or productive FTEs, were favorable to the flex budget of by 74.6 or 5%, coming in at 1,503.9 FTEs. Our non-productive for March was higher. It came in unfavorable to the budget by 24.2 or 11.5%, coming in at 210.1 FTEs. Looking at our total FTEs for March, they were favorable to the flex by 50.5 or 2.9% at 1,714.1 FTEs. For our total FTEs per adjusted occupied bed, it came in at 5.76, which was favorable to the budget of 5.87 by 1.9% or 0.11. Looking at our radiation oncology center treatments, the treatments came in at 360, which was unfavorable to the budget by 18 cases or 4.8%, and 70 cases favorable to March of 2024. If you move to the next slide, you can see that we still had received about 35 new referrals, so we continue to see a good number of referrals coming into the Radiation Oncology Center. Moving on to Washington Health Medical Group, you can see came in unfavorable to the budget by 7.5%. This was mainly driven in two areas in terms of primary care. We did have one of our physicians was out on a leave of absence due to family emergency. And then we also are below budget in terms of our FTEs and our providers in pediatrics, but we do have a new pediatrician that is starting in June. In terms of our specialty care visits were over budget by 1.2%. We saw that in cardiology and also in women's health. Looking at our outpatient statistics for the Development Corporation, overall, they were favorable to budget by 5.3% for March. The rehab center visits were favorable to budget by 195 or 12.2%. That was offset by both WASC and PSC that were unfavorable to the budget. WASC was unfavorable to the budget by 7.7%, and PSC cases were unfavorable to the budget by 23.7 cases. So just seeing lower ortho in terms of PSC And then for WASP cases, it was a number of physicians that were just out for that month. It was across the board, there wasn't one. Moving on to our financial statistics and charity care for the month of March, you can see our days cash on hand did go up. We saw 16 days more, went from 122 days in February to 138 days in March. This was mainly driven by, we did see our directed payments come through. If you remember, we do IGTs, and so we did see $4.4 million come in from the directed hospital payment program. This is the initiatives that provide supplemental payments to us, and also for QIP. So those two. Also, we did see some additional collections from Medicare, because if you remember, the month before we had a slowdown, so that was some pickup. We also saw an increase in our own, our team collecting better this month. And we did see some investment increases in $2.4 million, though, as we know, those are going up and down. We'll just leave it at that.
What day of the week?
Yes. Yeah. Charity care for the month of March was $384,000. We did have the increase was due to a patient who did qualify charity care, then submitted the information, and that case totaled over $300,000. Lastly, in terms of unhoused patients for July through March, you can see that we had 1,680 patient encounters, representing 761 unique unhoused patients. The total unreimbursement cost for the period came in at $5.7 million. As we talked about, this includes food, clothing, pharmaceuticals, DME, transportation, and other amenities that we so that was the month of March. Any questions? All right. Well, then I will move on to go on to Employee of the Month for April. Very excited to talk about Ramel Jabate. He's a cook. He's from Food and Nutritional Services. Ramel has been a part of Washington Health in the Food and Nutritional Services Department for over 22 years. He started as a per diem general dietary one and later became a full-time employee. He quickly proved himself to be a responsible and dedicated employee, which led him to be a trained cook. Working at the cafe grill during breakfast, Ramel became very popular and continues to be very popular with the hospital employees and visitors alike. His good attitude, excellent customer service, and delicious food led him to be well-liked by everyone he encounters. Becoming a cook allowed Ramel to be more creative with food preparation and also becoming a more active participant in menu planning and the product procurement process. He regularly communicates with management, he makes suggestions, and frequently asks for feedback on his cooking. He takes great pride in the food he prepares. During periods of high census, Ramel is always willing to help with other assignments, such as cooking for weekly Rotary meetings and other catering events. He is married with children. He enjoys short trips with his family, especially driving down the coast. In his spare time, we did learn a lot about pigeons, and he likes to race them, and he does very well with it, and he also likes to take walks with his dogs. So, yes.
Very pigeon in the...
No.
Very small. Those are racing pigeons.
Those are racing pigeons. They are. So, all right, let's move on to past promotion and community events. Find those. All right, moving to the first one, you can see on March 19th, talking a little bit about the trauma outreach team and what they've been up to. They did some Stop the Bleed training at the Fremont Community Ambassador Program for seniors. They had 40 attendees. Then also Dr. Stephen Zahner of sports medicine, did sports safety presentation for the Fremont Rush Soccer by Zoom. We had 15 attendees. And just another one I want to highlight is at Union City Culture Fest at the Kennedy Park in Union City. We did 30 blood pressure checks. Also, of course, you can see we were at Acacia Creek and also senior living apartments talking about nutrition for brain health and diabetes. Moving on, Dr. Chet Morrison was out in the community on March 26th, or did his Facebook and YouTube update on the trauma program, and had over 333 views. I do next just want to say, as Dr. Soleil mentioned, March 31st, we celebrated National Doctors Day. I think it was actually on March 30th. But we're very much appreciative of the exceptional group of physicians that we have throughout the healthcare system, whether they're in direct patient care or in leadership or governance roles. They all play a very important role in us being successful and providing excellent care to our community and our patients. And I do want to just show a short little video that was made for Doctors Day. All right, we have another one coming up in just a minute, but I do want to say that, as we mentioned, our trauma outreach team was at Acacia Creek, and they have an 8-week session in terms of matter of balance class, so like we talked about. Also, as we talked about earlier in Sheila's presentation that talked about the 70th anniversary luncheon, very much excited that we were able to celebrate the 70th anniversary of our Washington Health Service League. They are so appreciated throughout the health system, and they really, truly play an important role in the care that we provide. And I know our staff, our physicians, and everyone feels so strongly that we couldn't provide the care that we do to our patients and our community without them. So want to just show a short video that we also showed to them at the luncheon.
"70 years ago, a handful of women embarked on a mission to create a volunteer organization to assist with the creation of what was to become Washington Health. Now, 7 decades later, the Service League has expanded its support not only to our hospital, but to our growing community. A long legacy of service that now includes over 600 volunteers of all ages and walks of life, from high school and college students to professionals, to homemakers, to retirees, and everyone in between. Now, as you walk through the halls and departments at Washington Health, you'll see a Service League volunteer wherever you go, in both clinical and non-clinical settings. Each volunteer offering their time, talent, dedication, and humanity, with compassion, smiles, kindness, and very often, just a warm, caring touch to say, "I'm here, you're not alone." The Washington Health Service League is one of the greatest illustrations ever of community-based volunteerism. So today, we thank and celebrate every one of our volunteers, past and present, who have played such an enormous role in serving our patients, our families, and the entire community.
Thank you for 70 years of service.
We look forward to embarking on our 8th decade with you all.
That will continue to include every level of volunteerism.
We can't express how much we appreciate the generosity of your time and involvement, and all that you have sacrificed to give back to the people of our community.
Our community mission could never have happened without the help of you, our exceptional volunteers.
For your commitment, the impact you've made, and the lives you've helped change.
We are tremendously grateful. We look forward to working together for many years to come. Here's to the next 70 years and beyond. You are our heroes, and we are so very grateful to you all.
All right. As we all said, we're keeping our day job. Okay. All right, and lastly, you can see Dr. Eptemia did will be doing on April 9th in terms of today, what to expect at the infusion center. So, pictures you can go through, yep. That's pictures from Doctor's Day luncheon. And just to mention for April, in terms of the upcoming health promotion community outreach events, we're out in the community quite a bit. You can see with the Union City Egg Hunt on the 12th. Also on the 12th, Family Day at the Park at Newark Community Park. We have Earth Day, Fremont Earth Day event at the Downtown Event Center on April 19th. And also then, I do want to mention on April 23rd, Dr. Bonner is talking about advances in joint replacement for younger, more active patients on Facebook and YouTube. And then you can see in terms of another big event that will be at New Haven Days on April 26th at James Logan High School. And then, of course, important types of information for the community. April 29th, Maria Nunes at Kosher Retirement Community, and the 30th, Dr. Wong to talk about diabetes management, also at Senior Center Apartments, Pauline Weaver ones in Fremont. Then lastly, a few more that are coming up in May this is one of the May 3rd, I do want to just say, Spot Me free skin cancer screenings. I know that's very often a lot of people do popular come to that. Dr. Sunil Dwan is helping us with that. And on May 3rd, we do have, in partnership with our county supervisor, David Halbert, car seat safety event with seat inspections by Alameda County EMS, and it will be in the Washington West parking lot. So, then lastly, Dr. Singh, Pediatrics, Healthy Lifestyle for Kids on Facebook and YouTube on May 14th. I just want to remind everybody, May 12th, we have the golf and bocce ball tournament. It is our last one for this, so we really working to get everybody involved, and then also save the date for the 39th Annual Top Hat Gala on Saturday, October 11th. All right, that is my report.
Thank you. Does anybody have any questions? Okay, well, there being no further business, this meeting is adjourned. Thank you.
Great. Thank you.